Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. Today is a special day as we are celebrating our landmark achievement of reaching the 400th episode of the ACNS webinar. At this moment, we'd like to express our sincere gratitude to all the enthusiastic neurosurgeons around the world who follow our educational contents. We also like to thank our President, Prof. Yoko Kato, and our Vice President, Prof. Shubin, for their constant support they have provided for the last 5 years, and we hope to continue our program for the benefit of all the young neurosurgeons who turn to us to seek knowledge and excellence in neurosurgery. Coming back to today's webinar, the speaker for the first session of today is our honorable guest from Brazil, Prof. Wellington Paiva. Prof. Paiva is a professor of neurosurgery at the University of Sao Paulo, and he is a tenured professor and full advisor in postgraduate program in neurology at the USP. After his residency, he has completed his clinical research internship at the Spaulding Rehabilitation Hospital, Harvard. He works as a neurosurgeon performing complex brain and spinal surgeries at the Hospital Sirio-Libanês and Hospital Samaritino and Hospital das Clínicas. Since June 2030, he has been supervising physician of the neurosurgery division at the Hospital das Clínicas of USP. In 2014, he became departmental secretary of the Brazilian Society of Neurosurgery. He has received 19 awards in the field of neurosurgery, including the highest awards from the Paulista Society of Neurosurgery twice, the Brazilian Society of Neurosurgery twice, and the Pan American Trauma Society and the 2016 WFNS Trauma Committees. Since 2017, he has been a professor at the Global Neuro Foundation, Davos, Switzerland for Latin America. He is a member of the editorial board of 3 international publications and a reviewer for more than 20 journals. In 2019, he was hired as a member of Department of Clinical Neurosciences, University of Cambridge. He has published over 150 international scientific articles and 3 books, 1 in Europe and 2 in the USA. He has given over 100 lectures in 14 countries, and we are extremely honored to have him today with us. And today he will be talking about non-invasive methods for ICP monitoring. The speaker for the second session of today is our honorable guest from China, Professor Junming Zhu. Professor Zhu is a professor of neurosurgery, vice president of the professional committee of SIG and brain mapping of China Association Against Epilepsy. He is a board member of the neuromodulation committee of the Chinese Medical Doctors Association, vice president of the Zhejiang Association Against Epilepsy, board member of the 7th Functional Neurosurgery Committee of the Chinese Medical Association, and board member of the Hydrocephalus Task Force of the Chinese Society of Microcirculation Neurodegenerative Diseases Committee. He has been mainly engaged in the work of functional neurosurgery, mainly engaged in treatment of NPH, intractable epilepsy, Parkinson's disease and other movement disorders, intractable pain, etc. In recent years, he has published more than 20 papers at home and abroad and participated in the compilation of 6 professional books on modern neurosurgery and modern epilepsy. We are extremely honored to have him today at webinars, and today we will be talking about spinal cord stimulation in patients with spinal cord injury with paraplegia. The chair for the first session of today is our honorable faculty from Japan, Professor Aiki Suihiro. Professor Suihiro is a professor in the Department of Neurosurgery at the International University of Health and Welfare, School of Medicine, Narita, Japan. Dr. Suihiro is the Executive Director of the Japanese Society of Neurotraumatology and Japanese Society of Neurosurgical Emergency. His clinical interests are traumatic brain injury and neurocritical care. His research endeavors involve developing biomarkers, bedside neuromonitoring, and novel therapeutic interventions for brain injury. He is a principal investigator of a number of multicentric clinical studies on head injuries in Japan, and he has published more than 150 papers in referred journals and garnered several awards for his scientific research. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Chile, Professor Felipe Valdivia. Prof. Valdivia is a consultant neurosurgeon and chairman of the Clínica Almena de Santiago, Chile. His clinical interests are focused on the management of spinal cord injury, spinal tumors, complex brain tumors, and CSF disorders. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Aiki Suihiro.
Okay, thank you. Thank you for introduction about two chair and two speakers. First, here we will start the first lecture. So, speaker is Professor Wellington Pavia from Brazil, and his title is Non-Invasive ICP Monitoring. So, as you know, ICP monitoring is an essential tool in the treatment of head trauma. However, due to its invasive nature, its adaptation rate is not so high, including the Japan. In this context, non-invasive ICP monitoring has been gaining popularity in recent years. But I guess issue about the non-invasive ICP monitoring includes accuracy and reproducibility of the data. I would like to attend this lecture with an eye toward how these issues are overcome and how it is applied in clinical practice. So I'm looking forward to hearing his wonderful lectures. Please, could you start your lecture, Professor Javier?
Hi, everyone. It's a pleasure for me to speak about this important topic for patients with traumatic brain injury. We speak about no-invasive ICP monitoring. It's an important topic, especially for patients, for all neurocritical care patients, but especially for traumatic brain injury and for traumatic brain injury patients that live in Latin America, Africa, and some regions from Asia, because involves some aspects that we'll discuss in this lecture. I work here. I am associate professor of neurosurgery at University of São Paulo, and I work in Hospital das Clínicas, that is the university hospital from this university. Our hospital has almost 3,000 beds, and we are a level 1 trauma center with more than 400 patients with severe TBI per year. And here we have a neurotrauma unit with a neuro ICU and 15 neurosurgeons dedicated to neuro emergency and neurotrauma. When we think about the ICP monitoring, the standard care of management of patients with neurocritical conditions is invasive ICP monitoring with parenchymal, ventricular, subdural, different kinds of invasive, but the standard of care, the best option is invasive ICP monitoring. But there is some conditions that is not common to use invasive. For example, patients with moderate TBI, patients with 12 points in Glasgow Coma score, maybe it's not a common indication for invasive ICP monitoring. And there are other questions other concerns about complications of invasive ICP monitoring, involving hemorrhage, involving infections, involving not good position of probe. Then it's possible to discuss about other options when we think about these two specific questions. Another point important when we discuss this topic, it's about the international guidelines. The main guidelines are from US and Europe. The most famous, the most used, it's Brain Trauma Foundation guidelines. And in this kind of guidelines, it's not discuss important aspects about costs. Then it's different to use of some invasive techniques for high-income countries. When we discuss about low to middle-income countries, then it's important to discuss these aspects as well. And for moderation TBI patients, in face of a risk of complications of invasive ICP monitoring and other aspects is about costs, it's important to discuss the application of no-invasive ICP monitoring techniques. And that it's possible to use these techniques for all neurocritical care conditions like traumatic brain injury, intracranial hemorrhage, cerebral edema, hepatic encephalopathy, or cerebral malignant cerebral ischemia. And it's important to discuss this kind of techniques because we need new protocols for non-developing countries. I think that it's important to discuss about practical aspects in new future protocols. When we think about no-invasive ICP monitoring, it's important there are several ways to do, including neuroimaging with different classifications using CT or MRI. For trauma, it's not common to use MRI. You use CT with different kinds of classifications like Marshall score, Marshall classification, Helsing, Rotterdam, and all classifications involve aspects in CT that indicates possibility of intracranial hypertension. The use of ultrasound, we are discussing in details. The use of metabolic change with NIR, but it's not so good for severe TBI. And indirect ICP monitoring, we discuss all main ways to do this no-invasive ICP monitoring. And other we are discussed during this lecture. No-invasive methods have been considered with alternative to avoid complications like hemorrhage, like infections, and bad position of a catheter. Some possibilities involve the image evaluation, involve ICP waveform evaluation. Then we will discuss more detail some kinds that we are already using in practical settings in our center. When we think about the complications of ICP monitoring, it's important to see that we use invasive ICP catheter. It's possible to have infection in some case, hemorrhage in some case, dislocation, probe defective, disconnection, breakage of fiber optic, depending on the technology of this catheter. Then it's possible to have complications in invasive ICP monitoring, especially when you use intraventricular ICP monitoring, because in trauma it's hard to find the ventricle. It's possible because we have a small ventricle associated with intracranial hypertension, and because we have a midline shift, we have a hematome with a dislocation of ventricles, then it's harder to puncture of this ventricle. Some example in our center, we perform around 300 to 500, depends each year, invasive ICP monitoring, and it's possible to see complications of use of this kind of technology. For example, for this patient, it's good results, 10 years old, victim of a traffic accident. This child arrived in our center sedated with isocorpal pill, with this CT, this is the first CT. After stabilization of the patient, we put the intraventricular ICP monitoring. This is the first measurement with more than 14 millimeters in ICP evaluation. We did clinical measurement, clinical management of this intracranial hypertension with a saline solution and different kinds of ICU management of intracranial hypertension with good results after for 2 to 4 hours with control with new ICP monitoring showing 11 millimeters of mercury and with improve of compliance. Now we have this ICPA with a 2.3, this normal range from 2 to 5 millimeters. Then it's patients with good recovery without complications. Analyze these patients, they did use invasive monitoring for all cases. But we have complications for these other cases. These are patients victims of fall from 4 meters high with direct impact of occipital regions, 8 points in Glasgow Coma score. This is CT. We put intraventricular catheter, and this patient has presented infection and with not good recovery, and make this patient did not need the use of this kind of evaluation. For the other patients, a male with 29 years old, victim of motorcycle accident, arrived in our center with 6 points in Glasgow Coma score, with miotic pupils, with this patient presented anisocoria pupils after some hours, and this image with intraventricular hemorrhage and signs of diffuse injury. A new attendant in our service put the ICP catheter with bad positions, with complications. We had corrected this position, but this case is to show that it's possible to have complications to use of invasive ICP monitoring. And about the evidence, Professor Chestnut had published this classical paper in New England Journal of Medicine 12 years ago, showing that nothing proved the use of isolated ICP monitoring for patients with TBI. This paper has a lot of questions that need to discuss another opportunity, but it's to show that it's possible the use of ICP monitoring isolated is not enough to management of these patients. Regarding this, the current BTF guideline recommend the use of ICP monitoring for all patients with severe TBI to reduce mortality 2 weeks after trauma. And it's important, and there's several discussion in literature showing that intracranial pressure monitoring, invasive intracranial pressure monitoring, is the best way to management of patients with TBI, with severe TBI. But how I discussed, it's possible for some patients, for example, with when we don't have the standard invasive ICP monitoring, it's possible in some hospitals in Brazil, because the cost is a problem for many hospitals in Latin America, many hospitals in Africa. Another question is about the moderate TBI. We believe that invasive ICP monitoring is the best management of the patients, but some cases it's not possible to use this kind of technology, and we need to create a solution for the best management of these patients without the ICP monitoring. And it's possible to use non-invasive tools to measurement or to analyze behavior of ICP. And the main techniques that we use in our center is transcranial Doppler ultrasound, optic nerve shape using ultrasound, pupillometry, digital pupillometry, and a new technology that we use in Brazil called Brain for Care for analysis of ICP curve and analysis of compliance of intracranial compliance in patients with severe TBI. The use of transcranial Doppler, we use this kind of technology or technique for patients with subarachnoid hemorrhage to analyze invasive spasm. But in trauma, it has a space to estimation of ICP using pulse index and velocity of flow. We have studied this kind of technique in several patients, patients with TBI, patients with intracranial hemorrhage, patients with indication of the compressive craniotomy before and after. And we analyze aspects involving cerebral autoregulation and several cerebral hemodynamic aspects in patients with TBI. This technique is very interesting because has advantage about the cerebral hemodynamic evaluation in real time. It's possible to analyze several times a day, avoid unnecessary intra-hospital dislocation. In our hospital, we have some accidents when patients is moved from ICU to CT, from ICU to do some exams. Then it's we use transcranial Doppler. We believe that it's an important advantage. This kind of technology has low cost because you can use this kind of device to do other exams, other evaluation. And about the drawbacks, we think that it's exam that depends of experience of operator, and we have problem about results in ICP estimation using pulsatility index in patients with TBI, or analyze transcranial Doppler ICP estimation direct. Then it's possible to use an equation, but has some discussion in literature with some papers showing good results and some papers showing not good results. The use of pupillometry, it's an interesting way to analyze the behavior of ICP. It's possible to analyze the velocity of contraction of pupil, and it's possible to have some numbers that to analyze the possibility of intracranial hypertension. And the literature has a lot of papers showing interesting results in patients with neurocritical care, even using this kind of technology to have NPI, it's a neurological pupil index, and using this NPI to prediction of recovery after TBI with interesting results. Some researchers from Europe has used this kind of technology with interesting results about the control of ICP in dynamic analysis of this kind of technology. And the best paper analyzing this kind of technique was Orange study, published in Lancet Neurology 2 years ago. It's a prospective observational cohort study, led by Mauro Odo from Switzerland, and they showed interesting results. NPI had clinically and statistically significant prognostic value. It's interesting studies, but sub-analysis did after this publication, showing that it's not so precise or when you use for longitudinal analysis that now we are discussing about the whole of this technique. About limitations, it's hard to analyze confused patients with moderate TBI, for example, because we need to collaboration of patient when the patient is not in calm. Sometimes it's possible to have high injury or extreme bilateral edema, palpebral edema. The environment with light variations, it's possible to interfere about some research in the world, around the world, does not believe that it's interfere. And some patients with severe diabetes has some controversial results. About the use of optic nerve chip, it's a simple chip exam. Then it's easy to learn. It's possible. We try to use 1, 2, 3, 10 times. It's possible that we are a senior evaluator using this technology. When we do it, it's to analyze 3 millimeters after retin, and possible to evaluate the diameter of this chip, and it's possible to analyze associated with intracranial hypertension and the correlation with the dimension of this chip. This is an anatomic piece showing the eyeball, showing the optic nerve, and all when as involving the optic nerve. It's this region is contact with a subarachnoid space, and for this reason, when we have intracranial hypertension, we have increase of the dimension of this optic nerve chip. In the last years, we have a lot of new papers using this technology to evaluate patients with a neurocritical care condition, especially with severe TBI, and this is an interesting way to analyze this kind of patients, and some studies showing it's around 6 millimeters is associated with intracranial hypertension. Other studies showing 5.7, 5.8 with a good correlation. And for pediatric patients, we consider around 4.5 millimeters associated with intracranial hypertension. Our group had studied in animal and human studies this kind of techniques to evaluate, showing good correlation between invasive ICP monitoring and the estimation of intracranial pressure using this kind of ultrasound. It's an experimental setting that we had did this. We had this analysis comparing invasive with ultrasound in animal model of intracranial hypertension, showed a good correlation in longitudinal analysis with intracranial hypertension, and after treatments, for example, the use of saline solution, the use of different kinds of interventions, showing the good correlation and the rapid and the fast evolution of decrease the diameter of ONS in animal model. It's very interesting. Then it's possible to use CT as well. But about the ultrasound, when we use ultrasound, it's possible to find or to measure the ONS in around 97%. And using CT, it's possible. It's another technique. We had verified it's possible to measure in around 14.5 to 15% of patients, because using CT depends about the angle of the slice of the CT. Then in some patients it's not possible to use this technique. But it's possible to use CT or MRI, but it's not possible to arrive to reach this kind of evaluation. Our team has published some papers with a systematic review to studying this technique, and in this interesting review, we find some papers showing the use not only about the diameter of ONS, but as well the correlation between eyeball transverse diameter versus optic nerve shape, and was possible to analyze good correlation when we range this comparison, compare this kind of techniques. Then it's not use the diameter of optic nerve shape, but it's possible to compare optic nerve shape with eyeball transverse diameter, and it's possible to analyze the longitudinal aspects, the behavior of this, and correlation with intracranial hypertension. The advantage of this technique is a real-time evaluation. Like a transcranial Doppler, it's possible to avoid unnecessary intra-hospital transfer to do this kind of exam. Has low cost, the fast learning curve, and it's fast to do this exam, and has a good correlation with ICP in different publications. A drawback was not possible to continuous monitoring. Then we do this analysis, and it's not possible to continuous analysis, and unnecessary. We have no. We are not certain about the latence time of this range during the interventions at the TBI. One case with a patient with 45 years old with a DIS, it's in comatose with six points in Glasgow Coma score, and showing this CT. This is the first CT with subdural hematoma and important brain swelling. We did this optic nerve shape dimension 6.4 millimeters with high pulsatility index 1.8, and two kinds of no-invasive analysis, and after the improve after the clinical measurement. Another technique, the last technique, is about brain for care. It's a new technique that was developed in Brazil 10 years ago. It's possible to analyze the extension of a school to create ICP curve and analyze this compliance, intracranial compliance. Several studies was analyzed this technique and compare invasive ICP curve with this kind of non-invasive. Our team has published some papers in different journals the last 5 years. This is the most important paper that we published this year in Nature Digital Medicine. It's an important journal, and we compare invasive analysis with no invasive analysis, and we find around 3 millimeters of difference between those two kinds of evaluation. Now we are doing a great, huge multi-center analysis in cohort, comparing this invasive with no invasive patients with severe TBI, Marshall 1, 2, and 3, and analyze this comparison between invasive, no invasive. And the first patient showed a good correlation between two kinds of analysis, that it's invasive with a no invasive analysis. It's possible to create the PRX using no invasive, this kind of technology. Then with the advantage, it's a continuous and real-time evaluation of compliance of ICP curve, has a relatively low cost, and this technology is improving with a new kind of devices each year. About the drawbacks, no absolute ICP number, and there is a training to use this kind of techniques. It's important, in this paper published in Critical Care 2 years ago, we discussed about the importance of use of no invasive kind of technology. Then 1 year ago, we did this Brussels, this consensus meeting in Brussels, involving different medical associations. This consensus was published this year in a very important journal. It's Intensive Care Medicine. It's the most important journal in ICU for ICU doctors. And I took part of this consensus with some neurosurgeons and intensive care doctors around the world. And this consensus, we discussed about the use of transcranial Doppler, about the use of pupillometry, and the use of optic nerve CF dimension using ultrasound. And this consensus was supported by World Federation of Surgical Society and important intensive care institutions like European Society and Neurocritical Care. And then we use the CREVIS and CBICT protocol and Seattle protocols to discuss the use of the management of these patients, things of no-invasive ICP results using, for example, transcranial Doppler, using ONS with ultrasound, with regular evaluation 3 millimeters behind the retina, and analyze of these results, pupillometries, using NPI as the technique. Then we decided the best threshold using this kind of technology. Then NPI less than 3 can rise ICP associated with intracranial hypertension. The ONS more than 6 millimeters, pulsatility index more than 1.3. The no-invasive estimation using transcranial Doppler around 22. And about the changes from baseline to decide new managements use decrease more than 1 in NPI, more than 0.5 in pulsatility index. Beyond a threshold, we decide we create some algorithm to define the management of the patients based on no-invasive ICP, and which is important in this algorithm that we need to use 2 different kinds of no-invasive ICP estimation to define change the management of the patients. It's very interesting, And it's possible to use in patients after the compressive craniotomy. This paper showed that's important to control the ICP monitoring after the compressive craniotomy. Our team has published this year interesting meta-analysis showing the use of no-invasive and invasive techniques in patients, ICP monitoring after the compressive craniotomy. It's a very interesting discussion. And 3 weeks ago, we had published this interesting paper. Then we discussed some aspects of review of a classic Monro-Kelly doctrine after 214 years, when we discussed some important aspects of glymphatic system and the role of this kind of analysis is different for patients with severe TBI, with compromised autoregulation. It's a very interesting paper. And in this paper, we discuss as well the use of no-invasive neuromonitoring, not only ICU, not only hours after the evaluation of this patient, but the use of different kinds of technology in emergency room. Then, when this patient arriving in our emergency room, it's possible to use no-invasive, because the use of invasive, you need to do to ICU, you need to do to surgical center, to put the catheter, and the use of non-invasive is possible to begin the management of this patient with intracranial hypertension already in emergency department. Then we think that no-invasive ICP monitoring are still evolving. It's a very interesting tools to management of these patients. The invasive ICP monitoring is still with gold standard system, but in some special case, like moderate TBI, like patients that had some contraindications to use of invasive patients, and in some regions, some countries that cause its important concern. It's interesting, this technique they use, and we believe that in future we will have important information, new information about the use of these techniques. Thank you.
Thank you. Thank you for very, very excellent lecture, Dr. Professor Pavia. So before open the question, open the discussion, so my interesting is so first, I'd like to ask you my question. So how before widespreading non-invasive ICP monitoring. So in your country, how rate of invasive ICP monitoring is using in your countries?
Yes, my country has problem. It's like a continent, because we have a rich, huge country with a different management in different regions. In my hospital, we use invasive ICP. We prefer the use of ventricular ICP monitoring, and we have all devices that possible to use, like Camino, Codman, Halmedic, Spielberg, Pressure from France. But we prefer the use of invasive, and we use moderate. You use no-invasive in specific moments. For example, after 5 days after trauma, then we remove catheter, because we had important concern about the infections. And after 5 days, in some patients, it's possible to have compromised compliance, intracranial hypertension sign. Then we use no-invasive techniques, and we prefer use always two kinds of no-invasive. Then we use optic nerve shift dimension and brain for care, or optic nerve shift dimension and transcranial Doppler to analyze. Now we are start the use of pupillometry, but we had a small experience with this kind of devices. We use this kind of way to measure ICP, for example, in moderate TBI, in some patients with 11, 12 points in Glasgow Coma score. We prefer to use the no-invasive ICP monitoring.
Okay, thank you. So the key point of your lecture today, I think that we watched during the treatment of a severe TBI patient, we watched the value of ICP with invasive ICP monitoring, but it's changing. I mean, in now you are using a less invasive, non-invasive ICP monitoring. It means that you detect the compliance of a brain. It means that preventing exacerbation of TBI pathophysiology, because before rising ICP, you can detect the compliance, decrease the compliance of a brain. That's right?
Yes, we believe that in patients with severe TBI, intracranial hypertension, it's a very important concern, but not about the number, but about the compliance. And then patients has alteration in compliance. We prefer to remain with sedation. We prefer to stay with intervention to try to improve the compliance, since in patients with even patients with controlling ICP monitoring, because it's not the number. Now we use the literature use 22 millimeters about the ICP monitoring, but that 22 does not indicate that if a patient has a 20 is good, it's a 23 is bad. For this reason, the use of curve analysis to dynamic analysis, it's important in the management of these patients, not about the specific number. Obviously, a patient has a 3-4 millimeters, it's okay, and 35 is bad, it's okay. But there is a range between 15 and 25 that's important to analyze the individual analysis of these patients. And compliance analysis, it's interesting to get this information to decide the best management of the patient.
Yeah, thank you. So I think it's a very great concept. Thank you very much. So please, Professor, have a question. Please ask a question, please.
Hello, am I audible?
Yes, please ask.
Yeah, that was a very, very excellent presentation by Dr. Pavian, very informative. And he mentioned all the latest protocols, the CREVIX protocol and the CIVIC protocol, very enlightening. And like to bring to notice that when I read the CREVIX protocol, which has the clinico-radiological management of head injury, not when we don't have an ICP monitoring. So we found out that we have been approaching our patients in a similar way for around 2 or 3 decades here in Lucknow at KGMC, and we didn't have a invasive ICP monitoring, but our management rhymes with the CREVIX protocol, where clinical radiological, and we don't proceed directly to an early decompressive craniotomy. My second question is to Dr. Pavis. So, how do you relate the new ICCM protocol, the latent pressure reactivity index? How do you incorporate that in the ICP management? The PRX and the latent PRX studies, the compliance measurement.
Yes, I think that it's not only about the unique formation. It's possible to use pulsatile index using transcranial Doppler. It's possible to use NPI, but I think that it's hard to prove about the one way. It's include invasive ICP monitoring, because the decision about the best management of these patients, it's not possible using the unique number. It's not possible to use
exactly.
about their own ICP monitoring value, own pulsatile index, NPI, or you need to use the several information to decide the best option. Then it's possible to use no invasive in patients, and the discussion about no invasive ICP monitoring is more important in some regions like Latin America, like Asia, because we have several patients. It's different from Switzerland, it's different from some countries in Europe that has important publications, but without the practice with several patients. Then it's, for example, for us, we have in my hospital, we have around 400 beds in ICU, 400 beds in ICU. But we have a lot of patients with indication of ICU management that it's not enough. We have not beds enough to put this patient there. Then it's very common to use no-invasive ICP monitoring, because we need these patients need to remain in the emergency room or in other no ICU wards, and it's possible to use this kind of no-invasive for these patients. But I think that's not possible to use one information. We need to at least two evaluations to decide different intervention that we need to do for patients.
There's one more thing I need to ask, sir, that I also use ONSD as the marker. Have you encountered any study, or has anybody prompted that the anthropometric size of the skull has of different communities, like in Asia, America, and the African or the Europe, has any relation with the ICP because of the size of the skull, variation of the size of the skull? Is there any study that here the cutoff is 6 and the maybe in Asia we have 5.5? Is it any variable or the number is fixed?
Yeah, we think this is it's interesting, because the current idea in medicine, not in neurosurgery, but in medicine, it's the idea that every bar is the same bar, the same measurement of the arterial pressure, about the oximetry, about all situations. Then I think that's important. We need to create a number, and the option, for example, in optic nerve sheath, the use of 6 millimeters. The idea it's the studies showing the range from 5.6, 5.7 to 6.1. Then we decide they use the number that the large part of papers use it. But I think that it's possible to try individualize the management of patients in consensus or in guidelines. We need to do the way, especially for doctors without experience. Then we need to create the idea, or if you have not great experience with management of TBI, the suggestion is use this kind of guideline to best management that we have possible to use. But for example, if you have expertise in TBI with ICU guys, that is important because it's not all about the neurosurgery. We need to do a good ICU. It's in several hospitals in Brazil and Latin America. We have good neurosurgeon, but an ICU is not doctors with experience because our model in ICU has focus in cardiology and arterial
Exactly.
pressure and ventilation, but not great experience with a neuro ICU.
Not
For
with
this
the
reason,
device.
yeah. And for this reason, we believe that we need some guideline, any guideline, but it's if you have great experience, it's possible to individualize the management of the patient.
Thank you, sir.
Thank you very much, Prof. Paiva, for this wonderful lecture. So we can open this for further questions. Any question from Liu?
Thanks, Raja. Thanks, Prof, for very comprehensive talk. I have three basic questions. First, regarding the invasive and non-invasive intracranial pressure, which one have a more important role in terms of prognostication or aided in active management? Because both are interrelated. Second question, Professor, regarding the ICP monitoring and its value. Do you think that severe extracranial injuries such as lung and abdominal injury do play a role in terms of determining the algorithm of treatment? My last question, Professor, you talk about Monocali doctrine. Do you think that the ICP have the same role post the compressive craniectomy? If they do have importance after the compressive craniectomy, what is the role to put on the pressure transducer over the craniectomy site? Would that another option?
About the first question, I think that the pupillometry it's best studied techniques for prognostic patients. Then a group from Europe showed interesting correlation between NPI during all period in ICU with NPI not less than 3 with association with good recovery. Then this is the best studied technique in no-invasive. The other techniques were studied about the correlation between intracranial, invasive intracranial pressure with no-invasive results, but pupillometry was studied, analyzed with a prognostic aspect. Then it's possible to use this kind of technique to try define recovery of patients. As I say, pupillometry is the technique that we have less experience comparing with the other kinds of techniques. About the second questions, I will try to answer the question number 3, and I need to hear again the question 2 because
on severe extracranial injury, how it affects the algorithm.
Yes, I think that about the extracranial, it's possible to use ICP, no-invasive ICP. We had a great experience and published some papers in patients with hepatic delivery failure and the use of no-invasive, because in this kind of patients with hepatic failure, there is a problem about the coagulopathy, the important aspect of coagulopathy. Then we had used this different kinds of no-invasive analysis of ICP to decide the best management of these patients, because we have some problems with pre-hemorrhage using invasive, even using epidural catheter, we had complications. Then now we are preferring the use of a no-invasive ICP monitoring. And about the compressive craniotomy, we think that important to discuss about the monitoring patients, because for many neurosurgeons and intensive care guys. The idea is I did the compressive craniotomy, then it's finished. There are no treatment to do now, and now we wait and not to do now. But I think that is possible in some studies has shown important association with NRX, PRX behavior after the compressive craniotomy with recovery of patients. Even the number is different. The patients with intracranial hypertension less than 15 have best recovery and less mortality comparing with patients that have ICP monitoring with 18, 19, that it's a normal for people with close school is different in after the compressive craniotomy. And this is an important discussion. We are a discussion with Andres Rubiano, that it's chairman of Neurotrauma Committee of the World Federation, to maybe to discuss with guys from different parts of the world, including Asia, to do a consensus about this kind of ICP monitoring after the compressive craniotomy, because it's possible that the number is not it's not enough to do the compressive craniotomy. We need to manage patients with intracranial hypertension or intracranial compliance, alterations in compliance after the compressive craniotomy, because it's different the physiology of the brain after the surgery.
In continuation with Dr. Liu's first question, yeah, extra abdominal injuries also have to do with the ICP, because I read some of the good studies from Germany and Europe that decompressive laparotomy has also its role, positive outcome in reducing ICP in both cases where the patient has an associated blunt trauma abdomen or there's no abdominal injury. In those cases also, when we did a laparotomy, because the venous pressure was relieved, there was a sustained reduction in the ICP, and patients did have a good, favorable outcome. So a laparotomy is also a decompressive laparotomy is also a new option.
Thank you, Dr. Uday. You must watch our webinars. We had the speaker on our webinars here who presented decompressive laparotomy. So thank you very much, Professor Paiva. Just one last question from me. How do you improve your targeting the ventricle in emergency neurosurgery?
Yes, we need is a freehand the use of intracranial ICP monitoring. Then we need to for our resident, we perform a training in cadaver and specimens to train, but we think that some patients it's hard to do the ventricular catheter, and we use the traditional points and Cocker point and 5 millimeters, but we had calculates in some cases using or some Radiant, some software that is possible. It's a free software to use to calculate the best trajectory of ICP to reach the ventricular, the best ventricular point.
Thank you very much. We can go back to our chair, Professor Suhiro, for his concluding remarks.
Yeah, thank you. Thank you very much for excellent lecture. And I think this is maybe you change the world over TBI treatment. Thank you very much. So please give him the round of applause. Thank you.
Right, definitely. Thank you. Thank you very much to Prof. Paiva and Prof. Suhiro for this wonderful session. I would like to make you all aware that this has been broadcasted on WeChat, YouTube, and Zoom. And we are still waiting the number of people who have joined in. I will update you later. So we'll move on to the second session. If Professor Paiva or Prof. Suhiro would like to stay back, you're more than welcome, or you are free to leave at your own consensus. So I'll start the second session and hand this podium over to our second chair, Professor Valdivia, who will be saying a short introduction, and invite Professor Junming Zhu for his lecture. Prof. Valdivia.
Thanks. So for me, it's a very important honor to introduce Professor Chu Yuming in relation to the topic of today. He will talk the lecture spinal cord stimulation in spinal cord injury with paraplegia. I think for everybody, it's a big problem. Maybe in the border of our normal practice, the spinal cord stimulation is some techniques, some tools who don't use very common. And we appreciate this lecture to answer the question in relation to why, when, and how. Please, Professor Yuming, talk to your lecture. Thanks.
Okay, thanks to introduce. I will show with my presentation. Good evening, everyone. My name is Junming Zhu, a functional neurosurgeon from the Department of Neurosurgery at the second affiliated hospital of Zhejiang University School of Medicine. So it's the real pleasure to be here. I want to thank the organizer for giving me this opportunity. Today, I would like to talk about our recent work using the epidural electrical stimulation, or EES, to help patients with spinal cord injury, particularly this with the paraplegia. Over the past few years, this technology have developed repeatedly, and it's the opening up new possibility for restoring the movement and improving the quality of life. I'm excited to share our experience and what we have learned so far, and where I think this field is heading. First, let's take a look at the background of spinal cord injury. Right now, nearly 20 million people worldwide are living with spinal cord injury. And each year, we see roughly 500,000 new cases. So this is not a real condition. It's a major global health challenge. It places the heavy burden not only on the patients themselves, but also on the families, caregivers, and the healthcare system. When we look at current treatment options, they mainly include medication, rehabilitation, and various forms of the regenerative therapy, such as the stem cells treatment. These approaches are important, and they can certainly help the patient manage the symptoms and maintain function. But the reality is that none of them can fully repair the damaged spinal cord. For many patients, especially those with the complete injury, a meaningful motor recovery is still extremely difficult to achieve. And this is why epidural electrode stimulation has become such an exciting new direction. ES works by delivering the targeted electrode stimulation to the lower spinal cord. The idea is to reactivate the neural circuits below the injury, circuits that are still there but disconnected from the brain. By doing this, we aim to restore the ability to stand, take steps, and gradually relearn more complex movements. Over the past decade, along of the team around the world have shown that this approach can help some patients regain functional movement. Even the individuals who had been paralyzed for many years. So the goal of the ES is very clear: to help patients with spinal cord injury, especially this with the paraplegia, stand again, walk again, and eventually regain a great level of the independence in their daily lives. This is the motivation behind of work, and this is what I'm sharing with you today. So in 2022, Nature reported the STIMUL clinical trial conducted by the EPFL. This study applied high-frequency electrode stimulation with the precise spatial temporal encoding. Remarkable, 4 out of the 9 patients regained the ability to walk independently. The trial used the individualized electrodes stimulation can track the strong muscle contraction, and with the special temporal stimulation, the patient achieved continuous and coordinated muscle control. This marked an important step forward in restoring the mobility for the people with spinal cord injury. Since then, many leading research teams around the world have started a clinical trial using EES for spinal cord injury. In the West, several centers have made a major contribution. For example, Mayo Clinic have reported important breakthroughs in restoring the voluntary movement. The University of Louisville have carried out some of the earliest long-term ES studied in the patient with the chronic paralysis. And EPFL have pushed the field forward with advanced stimulation strategies and highly customized electrode design. Here in China, we are also seeing very meaningful progress. Groups at the Fudan University, Tsinghua University, Zhejiang University have both developed their own clinical programs using the EES, and their early results are very encouraging. Those centers have contributed not only the clinical experience, but also innovations in device design and rehabilitation strategies. Altogether, these efforts show that ES research is no longer limited to the few labs a handful of the patients is becoming the coordinated international movement with the different team operating the program from the different angles and all pushing the field toward the real clinical translation. Despite these promising early trials, we still faced several major challenges. One of the biggest issues is that spinal cord injury patients are extremely heterogeneous. Their injuries occurred at different levels: cervical, thoracic, and lumbar. The severity also varies widely from the completely to the incompletely injuries. And many patients have additional complications such as spasticity, chronic pain, blood pressure instability, blood and bowel dysfunction. Because of this variability, the outcome of ES could be quite unpredictable. At this stage, we still couldn't clearly define which types of patients are most likely to benefit from the ES. Currently, only a few patients regain some form of the independently walking, but others show only limited improvement, and some do not respond at all. A key reason behind this variability is lack of the standardized clinical protocols. We still don't know have the clear answer to several fundamental questions. Which electrode design worked best? Where exactly should be implanted? What stimulation parameters are optimal for different types of the injuries? And how should rehabilitation be integrated with the stimulation to maximize the recovery? Those are critical questions, and answer them will be essential if we want to make ES more constant, more predictable, and more effective for a wide group of patients. So recently, we launched a new clinical trial in Hangzhou and achieved very encouraging results in a short time. At the same time, we independently developed a completed EES system. It includes 16 contact electrode, implantable stimulators, wireless EMG acquisition, and a customized software supporting both clinical use and future research. As this is our preoperative procedure, including criteria or age from the 18 to the 65, incomplete cervical, thoracic, or lumbar spinal cord injury. Injury duration from the 8 to the 36 months, and HB above. Clinical evaluation include SNC-SI, FIM, WI-SCI, Ashworth, pen scale. We also use the PET CT scan, MRI DTI, MEP, and SSEP to assess the injury severity. During the operation, we performed the intraoperative electrical physiology testing to assess the activation effects. This process allows us to create the functional activation map for each patient. The map is critical for the tailoring the electrode implantation to the patient's individual neuroanatomy. In this way, we ensure the precise targeting and the best possible stimulation outcome. This figure represents the muscle activation patterns corresponding to all electrode contacts for presentative patients. This is our neuromodulation and rehabilitation strategy. We like to make the patient to produce the voluntary movement. We use the high frequency and low frequency combined. The rehabilitation strategy, first we use the single joint movement, the training, and multiple joint movement. Then the standing training and assistant walking, then to the ground walking and retained life. This is our first patient in the clinical trial. We launched the clinical trial in July of last year, and the ES surgery for this patient was performed in the March of this year. After 2 months of the intensive rehabilitation, the patient achieved the ability to walk independently. The patient is a 61-year-old male with the T3, T4 spinal cord injury, sustained more than 8 months ago. Despite receiving the 8 months of the rehabilitation therapy, there was no significant improvement in his condition. On examination, his lower limb mass strength was only grade 1 to 2, and he is classified as the ASIA grade C. The sensory level was at T4, and the patient also present with the urinary and fecal incontinence. Look at the video. The patient lied bad, only can move his leg a little. In this video, the left is ES off, right is ES on. By the third post-operative day, the ES have already enabled a high amplitude single joint movement in both low limbs. With the ES on the bilateral hip flexion, knee extension, knee flexion, the angles was significantly increased. The motor function recovery progressed in a sequential manner. By the post-operative week 1, the patient achieved continuous joint movement. by the week 2, he was able to stand. And by the week 4, he achieved standing leg swing. So from the video, you can look at. By the post-operative week 5, the patient achieved his first ground walking. By the week 6, the patient was able to walk smoothly. By the week 7, he managed to long-distance walking. And by the week 8, he could walk in the S shape, showing the better coordination and control. With ongoing training, the patient also demonstrated the progressive improvement in the 6 minutes walking test, achieving the both increased walking speed and a greater distance. At the 2 months post-operation, the patient had already achieved independent walking. Notably, he was able to walk with the cane as early as 6 months after surgery. Meanwhile, we also observed a significant improvement in his low limb sensory function, along with the restored bowel control. Now the patient have retained the independent daily life, marking a remarkable recovery. Here, I will show another case. As this goes, she was 24 years female who suffered T4 to T8 spinal cord injury from the fall over 1 year ago. On examination, her lower limb muscle strength was only grade 0 to 1. Her sensation was impaired below the T4 level. He also presents with common comorbidities, including the blood and bowel incontinence. So according to the H scale, he was classified as a grade B. So look at the video. The patient was unable to achieve the hip flexion and the knee extension before the ES. He could hardly make any movement in his low limbs and low sensation. By 2 weeks after surgery, with the ES, the patient can achieve the hip flexion and the knee extension. So from this video, you can look at 4 to 5 weeks after surgery, the patient can complete movement like the independent standing and the ES.
佩芬已离开会议。
慢慢放下去啊。About 2 months after surgery, with the continued rehabilitation, her progress becomes very clear. At this stage, she was able to stand voluntarily for up to 30 minutes, something he could never do before. She also began to initiate stepping movement, showing that her low limb strength and motor control were gradually returning. For a patient with the T4 injury and more than 1 year of the paraplegia, this level of the improvement in such a short time is truly encouraging. It shows that ES when combined with the structural rehabilitation, could help patients rebuild functional standing and take the first step toward walking again. So this is another case I would like to share. She was a 45 years old woman who became the paraplegic about 6 months ago. Her injury is located at the T12 to the L2 nerves. And before the ES, she was completely unable to stand or walking. Her sensory level in the lower limb stopped at L3 and almost below L3 had zero strength, meaning he have low voluntary movement at all in these muscle groups. Overall, she presents a typical low thoracolumbar injury, low standing ability, low weight-bearing capacity, and very limited sensory function below the lesion. So this is the MEP and SCP. 1 week after ES surgery, she was already able to stand with support. This is a major step forward, considering she had absolutely low standing ability before. By 2 months after surgery, her progress became even more impressive. She was able to walk about 50 meters in 6 minutes with the training, something that was completely impossible for her pre-operatively. At the same time, his no limb muscle strength improved significantly. The major muscle growth in his neck recovered to about grade 3 means he could lift his neck against the gravity, and importantly, the sensation in the sole of his feet also returned. 2.5 months after ES, she was able to walk about 62 meters in a 6-minute test. Here, I would present a case of the quadriplegia caused by the cervical spinal cord injury. This is a 67-year-old male patient who became paraplegia more than 10 months ago after a traumatic accident. His spinal cord injury is located at the C3 to C6 levels. When he came to us, both of the upper limbs showed severity, spasticity, paralysis with the Ashworth score at grade 5. The muscle strength in his lower limbs was extremely weak, essentially grade 0 to 1. He also suffered from the significant neuropathic pain, and he had complete loss of sensation below the level of the T4. After ES procedure, this patient showed a clear reduction in the muscle tone in both the upper and the lower limbs. His Oswald scale dropped from the grade 5 to about grade 3 to 4, which is a very meaningful change for the daily function. We also saw a notable improvement in his motor abilities. Before the surgery, he couldn't sit up on the wound at all. Now he can sit up independently, and he is even able to feed himself. He can pick up bread and eat on his own without assistance. This is a 31-year-old woman who became paraplegic more than 1 year ago after a car accident. Her injury is at the T4 thoracic nerve. Before the surgery, his lower limb strength was quite limited. The right leg had the muscle strength around grade 2 to 3, while the left was only grade 1 to 2. He also had reduced the night torch and a pinprick sensation below the T4 level. In terms of the autonomic function, he was able to manage the urination on his own, but he did experience the occasional bowel incontinence. Overall, her neurological status was classified as H grade C. Although worse than the right side, more compensatory and stand better in the extension than in the flexion. And before the surgery, he relied almost completely on his arms just to stand up. He could not support his own body weight with his neck at all. When it came to walking, he still needed to external breathe. His right neck had slightly better control, but his left side was much weaker. The knee could not knock, so it could not support her during the stepping. Overall, his ability to stand and walk is extremely limited, and he depended heavily on his upper body and assistant device. So we use the MEP, SEP to assess the neurological function. We also use the PET-CT scan and the MRI DTI. The PET-CT scan suggests that a metabolism of the calf and semi-tendinous was relatively high, and the right side was So during the operation, we performed the intraoperative electrophysiology testing to assess the activation effects. In this way, we ensure the precise targeting at the T12, L1, and the best possible stimulation outcome. The mapping of the electrode contact, the muscle relationship. So with the ES, the patient can do the ankle flexion exercise. So post-operative, 4 weeks, the patient begins to stand without a breath and try stepping. By the 8th week after surgery, with the intensive rehabilitation, her low limb strength begin to show a steady improvement. Here, motor AIS scale for the lower limbs increased by the 15 point, and his sensory AIS score improved by another 5 points. In simple terms, both his muscle strength and the feeling in his neck were clearly getting better. This change should be like the numbers, but clinical, they represent a meaningful progress. So far, we have performed the ES surgery on the 7 patients with the throat lumbar spinal cord injury. Although the follow-up period is relatively short, ranging from just 2 to 8 months, the results are very encouraging. 2 patients have already regained the ability to work independently. 3 patients are now able to stand on their own, and almost all the patients have shown significant improvement in the motor and sensory function. Some patients have the blood pressure recovery. Here, I will represent the detailed change in the lower limb muscle strength of the 4 patients before and after ES surgery. We can see both the muscle strength and the control of the movement becoming progressively better. So, to conclude, our finding highlights the several important points about the use the ES in spinal cord injury. First, ES can effectively restore both motor and sensory function in the many patients. When the stimulation is delivered in the precise, physiological, meaningful pattern, and when it is combined with the structural rehabilitation, the patient have much better chance to rebuilding character, voluntary motor control. So stimulation alone is not enough. The combined with the ES and the rehabilitation is essential. Secondly, we see a clear difference in the recovery based on the injury level. Patient with upper thoracic injury, roughly the T1 to T10, tend to be achieved a better outcome if they retain the residual function. However, for patients with injury around the T11 to L2, the results are much more variable. This highlights the need to better understand which patients are the most suitable candidates for the ES. Third, the sub-threshold stimulation appears to be a key mechanism. This type of stimulation does not directly produce the movement, but it enhances the excited ability of spinal networks so that the patient can regain the voluntary control. This approach may be critical for the long-term function recovery. Finally, our current spinal cord stimulation devices are not designed especially for ES in the paralysis. The lack of the precision, flexibility, spatial temporal control required for the optimal motor recovery. Therefore, there is a clear need for last generation ES systems. System the purpose built for the motor restoration with more channels, higher resolution, smart programming, and real-time adaptability. Together, this point should ES has strong potential, but further innovation in the patient selection, stimulation strategy, rehabilitation protocols, and device design is essential if we want to maximize the outcome and expand the number of the patients who can benefit. At last, I want to sincerely thank our multidisciplinary teams, as well as the company who provide the hardware and technical support. Thanks.
Thank you very much, Professor Yunin. It's a wonderful lecture and topic. And let me make two questions. One is in relation to the mechanism or action of the stimulate. Can you explain or give our more information in relation to what is the real mechanism who you have the possibility to return motor function, some sensorial function with epidural stimulation? And the second question is in relation to the position of the electrodes. That's meaning, do you think if you change to intradural electrodes, it's different, the results?
Okay. The first question, actually, we don't know exactly the mechanism how the ES work, but according to the paper, as they said, they can enhance the brain signal to the so they can they enhance the signal from the brain. So the patient before the ES, he couldn't move his the limbs. After the enhanced signal, they can move now. This is just one mechanism. For the second question, the electrode position. So I will show my I showed the PP. So during the surgery, we perform the intraoperative electrode physiology testing. We see that every contact activated the muscle. So, for example, this contact can activate the GM, the VL, and the RF. So we make the contact and the muscle the mapping. So according to this, so we normally put the electrode at the T12, L1, but every patient have a different the position.
And do you use this system for some patient with Parkinson's disease with a very high problem with to walk? Can you use the electric stimulation for this for the spinal cord for the patient with Parkinson's disease?
Yes, for the Parkinson's disease, this for the the patient have the walking problem, we try a few patients where we use the SCS, so make the patient walk stably. Yes.
Okay. Thanks. It's a spectacular lecture. Thank you very much.
Thank you very much. It was indeed spectacular, and we are like in awe of your technique and amazing results, I must say. I just want to know what is the cost of the device, entire treatment.
This cost in China maybe trans to the
US dollars.
US dollar. Just 1 second. 40,000 US dollar for every patient.
40,000.
But this is a clinical trial for every patient with the free.
Okay, enrolling patients are free. Okay, right. Thank you very much. So now we have come to the end of this webinar. I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Dr. Welling Singh Paiva and Professor Junming Zhu, as well as the chairs, Prof. Aike Suihiro and Professor Felipe Valdivia, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host Dr. Liu Boon Singh for joining me today. Until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.